Good morning. Welcome to the second day of our June U.S. Advisory Committee on Immunization Practices meeting. Going to start out quickly so we keep with appropriate Federal Advisory Committee rules and go around with a roll call and a restatement of any conflicts of interest. And we will start here on my right with Anna.
Bennett, no conflict.
Pellegrini, no conflict.
Rubin, no conflict.
Harrison, no conflict.
Ariel
Vasquez, no conflict.
Queen Beasley, my institution receives finances, resources from Merck for clinical trial.
Chairman, no conflict.
Kemp, no conflict.
Bocchini, no conflict.
Reingold, no conflict.
No conflict.
Heron, no conflict.
Capizal, no conflict.
And Tempty, no conflicts. I'm going to start out by just picking on Brana Warshawski here, who is our neighbor from the north. And I believe, if I'm not mistaken, this is your last meeting as liaison for, I keep on forgetting, the National Advisory Council on Immunization. Is that correct? Or Committee on Immunization. And Brana's been with us for several years and providing us guidance from Canada, and we just thank you for your time, your service, your enthusiasm, and interest. So thank you very much.
Thank you. It's been a pleasure.
And I also have to, I think it was John Scott who informed me recently that this is NASI's 50th year as well, so happy birthday. I think we're going to go right into a quick update on typhoid vaccines, and then we will go through the agency updates.
Thank you. Good morning. So the most recent ACIP recommendations for typhoid immunization were issued about 20 years ago, back in 1994. Because some of the information in this document is now out of date, we propose to update it with new information about typhoid epidemiology, vaccine safety, and vaccine availability. Because typhoid fever is uncommon in the United States, I'd like to provide some brief background. The disease is caused by Salmonella enterica serotype typhi, and contrary to most other Salmonella serotypes, humans are the only reservoir. Infection is usually acquired from food or water contaminated with human feces. Infection, the incubation period is relatively long, ranging from about 6 to 30 days, and the disease usually has an insidious onset with gradually increasing fever, malaise, headache, and anorexia. Typhoid fever can be severe and deadly, particularly if untreated. For example, a U.S. study from the 1940s reported a case fatality rate of over 10%. Life-threatening complications include septic shock and intestinal hemorrhage and perforation. The disease can now be treated with one of several antimicrobial agents, fluoroquinolone, beta-lactam, azithromycin, chloramphenicol, or trimethoprim sulfamethoxazole. However, antibiotic resistance is common and increasing in many parts of the world, placing greater importance on prevention tools like vaccines. Although typhoid fever is uncommon in the U.S., it remains a major problem on a global scale. In the U.S., about 400 cases are reported annually, compared with an estimated worldwide burden of over 20 million cases per year. 90% of U.S. cases are associated with foreign travel, and 75% of these cases are associated with travel to South Asia. So this table shows the 3 typhoid fever vaccines included in the 1994 ACIP statement. There's the oral live attenuated TY21A vaccine, the parenteral VI capsular polysaccharide vaccine, and the parenteral whole cell heat phenol inactivated vaccine. Currently, the oral TY21A vaccine and the parenteral VI CPS vaccine are still marketed in the United States. The heat phenol inactivated vaccine, which was associated with high rates of fever and other systemic reactions, was discontinued back in 2000. The 2 available vaccines have been estimated to have similar efficacy at about 50%, though individual reports range from 45 to 80%. Because immunization offers only partial protection against typhoid fever, travelers and other persons at risk should follow recommended food and water practices. Additionally, these vaccines offer little or no protection against paratyphoid fever, which is an increasingly common disease that causes symptoms similar to typhoid fever. Regarding the choice of vaccine, the most recent ACIP recommendations state either oral TY21A or the parenteral VI-CPS vaccine is preferable to the inactivated vaccine because the now discontinued inactivated vaccine caused substantially more adverse reactions and was no more efficacious. Typhoid vaccine is indicated for travelers to endemic areas, household contacts of carriers, and laboratory workers who work frequently with Salmonella serotype typhi cultures and specimens. Travelers and clinicians can now consult cdc.gov/travel to find the most updated recommendations for each country. And as of 2011, CDC no longer recommends typhoid immunization for travelers to 26 countries, including Eastern Europe. So in summary, we propose no substantial changes to the existing typhoid recommendations, and for this reason, we do not plan to convene a work group. However, we would like to ask you all to vote at a future meeting on a new ACIP document with updated information on typhoid fever epidemiology, vaccine safety studies, and vaccine availability. Thank you.
Thank you very much. Are there any questions regarding typhoid? And if not, I think we'll be looking for the updated statement and a vote on that. We'd
like to.
Okay, thank you very much.
Thank you.
Let's move ahead then with the agency updates, starting with CMS. Dr.
Our them to take advantage of optional provisions in the Affordable Care Act related to coverage of preventive services. We're also encouraging states to take advantage of our quality measures, optional quality measures, which include measures related to immunizations. On the Medicare side, we are also ensuring that all of our quality measures are aligned. So we're looking at measures to ensure that Thank you.
Thank you. Dr. Geib, Department of Defense.
Good morning, everyone. Just not much to update today. Just a couple of points with regards to JEV. Again, I've said this before in previous meetings, but services have had no known cases of JE in active duty for more than 2 decades. But we're continuing to reinforce ACIP recommendations, use of the vaccine in high-risk settings, need for careful screening, and assessment of risk conditions. Additional implementation guidance should be coming out from NVAC to educate our community. We're working to better inform our providers and beneficiaries on potential changes to polio immunizations for certain countries. So far, there has been no problem for DoD personnel with regard to this. With respect to adenovirus, it's our type 4 and 7 live oral vaccine that we've been using since October of 2011. Continues to be a very, very successful vaccine with probably over 100,000 lost training days saved due to far fewer hospitalizations had prior to reinstitution. And then lastly, I would comment on HPV. DoD continues to work on this area. There have been challenges, but we continue to work on that. Our program. That's all I have.
Thank you. Dr. Kissinger?
Good morning. Requirements. Large commercial pharmacy chains around the country to allow others to receive at that company, and then those records will be transferred to our organization records, and we're very excited about that.
Good, thank you. Dr. Sun, FDA.
Good morning. Wellington, okay. Not many updates today, but I just want to mention that last week I have worked very closely as well as Novartis, Max Zero address college outbreaks, Santa Barbara, an example where we were available investigational vaccine that's currently under development in public health.
Thank you. Dr. Houston from HRSA.
Good morning. Just have a few updates. The notice of proposed rulemaking to amend the vaccine injury table to add intussusception as an adverse event associated with the rotavirus vaccines in some circumstances was published in July 24, 2013. The second public hearing was held on April 28, 2014. And the final rule is in the process of being developed. On March 31st, 2014, the Health Resources and Services Administration published a notice of proposed rulemaking proposing a pandemic influenza countermeasures injury table for certain covered countermeasures identified by the Secretary in several Public Readiness and Emergency Preparedness Act declarations. The public comment period ended in May, and the final rule is in the process of being developed. The Advisory Commission on Childhood Vaccines made several recommendations to amend the vaccine injury table during several meetings. The last meeting was held on June 5th, 2014, and those recommendations are being considered. And finally, increasing numbers of petitions are being filed with the National Vaccine Injury Compensation Program each year. In FY12, 400 petitions were filed. In FY13, 501 petitions were filed. And it is projected that in this year, 533 petitions will be filed with the program. Thank you.
Thank you very much. Ms. Groom, Indian Health Service.
Thank you. Good morning. I thought I'd share a little bit about our adult immunization activities, especially in light of the conversation yesterday. In the Indian Health Service, we do have electronic health reminders in our EHR. So to Dr. Kemp's point about the low-hanging fruit, this is one of the things that we've instituted. Our adult vaccine coverage is something we continue to monitor on a quarterly basis. Our Tdap coverage for adults 19 and older is 70%. Our zoster for 60 and older is 39%, and our pneumococcal polysaccharide among those 65 and older is 75%. So we really attribute that to the fact that we have these reminders in place. We're also looking to explore the implementation of a composite immunization measure as a performance measure. So instead of monitoring them individually, to look at bundling those, and we're looking at age-appropriate vaccination with Tdap, zoster, and pneumococcal polysaccharide, and we'll be implementing that across the agency this year. And we're also very interested in this concept that came up yesterday about bundling it with other preventive care measures. So not just looking at immunizations, but looking at colorectal cancer screening and pap smears, and sort of bundling these measures as a preventive health measure, and so that's something that we're also exploring. And then along those lines, we're exploring doing some flu fit projects. I don't know how many people are aware of that initiative that Kaiser tried last year, and then the American Cancer Society is supporting, of bundling influenza vaccination with the provision of colorectal cancer screening fit kits. And so we're very interested in that as a model. I don't know if the flu will help the colorectal cancer screening or vice versa, but that's something we're also looking at piloting in some of our sites for the upcoming season. Thank you.
Thank you much. Dr. Gorman, NIH.
Thank you and good morning. I'd like to spend a few minutes highlighting 4 NIAID programs and give an update on one set of clinical trials. So at a White House event on December 2nd, 2013, to mark the 25th annual World AIDS Day, President Obama announced that the National Institutes of Health plans to redirect AIDS research funds to expand support for research directed towards a cure of HIV. NIH plans to invest an additional $100 million over the next 3 fiscal years to this increasingly promising area of HIV/AIDS research. Dr. Fauci noted at this meeting that our growing understanding of the cellular hiding spaces or reservoirs of HIV, the development of new strategies to minimize or deplete these reservoirs, and encouraging reports of a small number of patients who have little or no evidence of virus despite having halted antiretroviral therapy, all suggest that the time is ripe to pursue HIV cure research with vigor. The second program I wanted to highlight is the NIAID Concept Accelerator Program. It's commonly known as CAP. The CAP is a team of individuals charged with identifying promising early findings and facilitating their translation into products suitable for advanced development. These individuals seek active engagement with entrepreneurs and scientists to nurture early programs and accelerate their progression to the clinic. These individuals offer strategic advice to help shepherd candidate products through the research and development process, including formulation and formation of product development teams with a broad base of experience. And this team also can explain and facilitate access to NIH-provided core research services. The next program is the NIH Influenza Research and Surveillance Network that has just recently been refunded. Not okay, the NIH Centers for Excellence in Influenza Research and Surveillance Programs continues and expands the Institute's animal influenza surveillance program internationally and domestically and focuses on several high-priority areas in influenza research. The future direction of the SEERS program includes continued surveillance research, determining mechanisms underlying transmission, both from animals to humans, and determining mechanisms for the duration of humoral immunity. And we're having trouble with our electronics. In the report that I'll submit, there will be a list of the SEERS sites. Forgive me. Despite the success of vaccine therapy, people still do get sick, and when they do, we treat them with antibiotics, and antimicrobial resistance is an increasingly troublesome problem that NIAID is addressing with the antimicrobial leadership group. So they launched this group in 2013 to address antibacterial resistance, and the ARLG, or the Antibiotic Research Leadership Group, has developed a process for identifying the most pressing clinical questions in antimicrobial resistance. The studies conducted by the ARLG may include clinical testing of new drugs to treat multi-drug resistance gram-negative bacteria, evaluating diagnostics devices in clinical settings, evaluating the effectiveness of new antibacterial stewardess programs, and optimizing treatment regimes to reduce the emergence of resistance. The Antimicrobial Research Leadership Group is drawing on the creativity of the global research community by inviting concept submissions to identify and address antimicrobial resistance priorities. At this time, the ARLG is conducting 3 studies, is in the startup phase for 6 more, and is planning 3 more studies at this time. And lastly, as a research update, I'd like to talk a little bit about H7N9. In response to the outbreak of H7N9 last year, NIAID conducted 2 clinical trials which enrolled healthy adults 19 to 64 to evaluate an investigational H7N9 vaccine developed by Sanofi Pasteur. The candidate vaccine was made from an activated H7N9 isolated in Shanghai, China. 2 adjuvants, MF59 and ASO3, are being tested with the investigational vaccine because previous research involving other H7 influenza viruses have suggested that 2 doses of vaccine without an adjuvant may not produce an immune response adequate to provide effective protection. In pandemic situations, adjuvants can be used as part of a dose-sparing strategy, which would allow the production of more doses of vaccine from available supply of viral antigen, thereby allowing a greater number of people to be vaccinated more quickly. The 2 clinical trials have completed enrollment of approximately 1,700 human volunteers. The data gathered from those trials is being analyzed, and the manuscripts are being prepared. Thank you.
Thank you. Dr. Ernstein, NVAC.
The NVAC last met on June 10th and 11th. We heard presentations from ASTHO and AIM regarding challenges they were facing in supporting and improving upon the infrastructure for immunization programs. Also heard about a potential $50 million cut approximately in the President's budget submission for FY 2015 compared to 2014 in the immunization funding line, and passed a resolution asking for the rationale behind that budget cuts, given the challenges being faced on infrastructure. We have three major working groups. One, the maternal immunization working group, which initially focused on how we improve compliance with current ACIP recommendations. That report was finalized and focuses on recommendations in 5 main areas: enhancing communication to address safety and effectiveness, maximizing obstetric provider recommendation and administration, focusing on efforts to improve financing for immunization services during pregnancy, supporting efforts to increase the use of electronic health records for immunization for obstetrical providers, and overcoming issues with regard to vaccine liability laws that are barriers to vaccination of pregnant women. In the report, there's a sentence that specifically says that the ACIP could consider developing a separate statement that consolidates all of the information for pregnant women into a single document with updating as new information becomes available to make it easier for obstetric providers to access all of the information in one document instead of having to go to separate documents. There is a working group on improving uptake of HPV vaccine. It endorsed the report from the President's Cancer Panel to improve immunization, and NVAC will continue to monitor the status of implementation of the recommendations of that report. It continues to work on addressing issues with regard to vaccine confidence or hesitancy, and we expect to get a set of recommendations at our September meeting to be finalized. There were a number of other things we heard, such as the status of vaccine innovation and research, specifically with regard to influenza, and I think the NVAC will, over time, try and deal more with the issue of incentivizing innovation and research to develop new and improved vaccines.
Thank you. And Dr. Gillen?
So thanks to the timely and on-time presentation of the adult immunization program, I was able to give part of my report yesterday highlighting the adult plan and the NQF quality measures. 2 other things I'd like to mention. So we supported the Agency for Healthcare Research and Quality, ARC, to conduct a review of vaccine safety. They're going to, the part of that report will be published in Pediatrics next week, and then other parts online. So look for that. And then separately, we were unable to, because of the schedule of the ACIP, we hope to have the Institute of Medicine return to give the committee an update on their smart vaccine tool. So hopefully they'll have a chance to do that in a coming meeting. They are currently in the 3rd phase of this, but if you want to go Google, if you want to spend 90 seconds to learn about this, go Google Smart Vaccine IOM, and you can watch Harvey Feinberg presenting this vaccine decision tool. Thanks.
Thank you very much. And I think we have a brief liaison report from Dr. Freihofer.
Sandra Freihofer for American Medical Association. In November of this year, 2 reports of interest to this group will be presented to the AMA House of Delegates. One is on immunization exemptions, and this is a joint effort of the Council on Science and Public Health and our Ethics Committee. The other is a joint council report on pharmacist administration of immunization. So if your organizations have any policy on these topics that you'd like to share to be included in the discussion as these reports are written, you can email me that information or contact Barry Dickinson, who is the secretary for the AMA Council on Science and Public Health.
And saving the best for last, Dr. Shuket for CDC.
Sure. The international health regulations and World Health Assembly have updated guidance on polio vaccination given the state of the world's polio eradication effort. And in the next several days, expect an MMWR clarifying what this means for Americans traveling or living abroad regarding their need to have documentation for a recent polio vaccination. The next National Immunization Conference is going to be September 29th to 30th at the Crowne Plaza Ravinia in Atlanta. This will be the first National Immunization Conference in 3 years. we really hope people will be able to attend that. It's going to be a 2-day conference instead of the previous 4-day conferences. Between now and the next ACIP meeting, there will be several reports on immunization coverage that we hope partners will be able to help promote and highlight. July 25th, we'll be reporting the teen immunization coverage and also the HPV coverage as a standalone, too, in the same MMWR. In August, you can expect the toddler coverage, and in September, the kindergarten coverage and exemptions. And then in light of the key priority areas that we have for our nation's immunization right now in terms of modernizing the information immunization systems in light of changing health IT and addressing lagging HPV vaccine coverage in teens, there'll be a number of funding opportunity announcements over the next several weeks that will address those two big priority areas.
Thank you. And Dr. Plotkin?
Yes, the audience may be interested that recently I attended a meeting sponsored by NIH on the immunologic problems of vaccine development because of, for example, waning immunity, how to fix that problem. And I hope that NIH will continue and fund additional research on this issue. But the meeting went over a large variety of problems and was quite useful, I think. Secondly, those of you interested may want to look at an article just published in Nature Immunology by Wayne Koff, Ian Gust from Australia, and myself, which speaks to a human vaccines project, again, addressed at the immunologic problems of developing new vaccines, and the idea being to create a project much like the genetics project to push vaccine research forward.
Thank you very much. With that, I will ask Dr. Bennett to come up to introduce the 13-valent pneumococcal conjugate vaccine topic, and also just mention that we have 3 public comments registered that are appropriate for pneumococcal, so we'll take those at the end of the session with acknowledgement that at least one of the speakers needs to be on a plane fairly soon, so thank you.
Good morning. It's my pleasure to introduce the pneumococcal session for this morning. And as usual, I first want to thank our work group who has been very diligent since the last time we've seen you. And in particular, of course, Tamara Pilishvili, because she really keeps us together, keeps us on track, and keeps us working hard. This morning, I won't review the terms of reference. Today's session is mostly directed towards the first, which is to review current data on the efficacy, effectiveness, immunogenicity, and cost-effectiveness of pneumococcal vaccines. Today, we're going to give you a very brief update on our work related to the 3-dose infant schedule, but then we will spend the bulk of this session on PCV13 use in adults. So just to remind you, in February, we presented a very laborious grade review, which essentially indicated that there was strong quality evidence and Category A recommendations for both 3+0 and 2+1 versus no vaccine. However, there was very limited evidence comparing 3-dose schedules to 4-dose schedules. Although we have evidence from other countries using a 3-dose schedule, we are not able to really compare the two schedules directly. So we continue to observe direct effects and indirect impact of PCV13 in the United States, which helps us in our deliberations about how to move forward on this. The work group has been working with the AAP and AAFP, and a number of the potential projects are listed here. We are still in the decision-making process. Some of these have gone forward and some are still waiting to go forward. We will be updating the ACIP at a future meeting on the deliberations of the work group related to a 3-dose schedule. The focus of today's session, however, is on the use of PCV13 in adults. And I just want to recap a little bit of the background for this. If you recall, this vaccine was licensed for use in adults over the age of 50 back in 2011. It was approved on an accelerated approval pathway, essentially based on non-inferior immunogenicity compared to PPSV 23. The indications on the license included prevention of both pneumonia and invasive disease in adults 50 years of age and older, and it created prevention of disease due to the 13 serotypes that are listed on the slide. One condition of approval was a randomized controlled trial of PCV13 against pneumonia among adults over the age of 65. This trial was conducted in the Netherlands. It's called Capita, and we're going to hear about it today. The reason that we didn't go forward with a recommendation in 2012 was twofold. We presented the grade review and showed the immunogenicity results from the phase 3 trials at that time. We also discussed the cost effectiveness and the public health impact, but we felt that we really wanted to defer a recommendation until we had more data. The most important data was from Capita, which you will see today, and then the second most important was really reviewing the indirect effects of PCV13 use in children. And as you know, we've been presenting those data to you all along in the course of the last couple of years. We did recommend a dose of PCV13 for those who were immunocompromised in addition to PPSV 23. So those recommendations have been in effect and vaccination is moving forward. The objective for today's session is to review the information that we now have that we've been waiting for the last couple of years. We will also present specific policy options for your input and also so that we can decide on what our specific recommendation will be. However, we will not ask the committee to vote today because there are many complications related to making a recommendation for this vaccine, including the impact of the indirect effects on the older population, and also simply implementation issues that we still need to address. So we'll review the results of Capita and the new cost effectiveness analysis, and then tomorrow we'll discuss the considerations for PCV13 use in adults over the age of 65. So today's presentations include a presentation on Capita by Rosalind Hollingsworth from Pfizer, a presentation on the public health impact and cost effectiveness of PCV13 by Charles Stoker, and then considerations for its use by Tamara Pilishvili. Thank you very much, and I think it's going to be a great session. Dr. Hollingsworth?
Okay, thank you. Good morning. I am grateful, Mr. Chairman and ladies and gentlemen of the committee, for the invitation to speak to you this morning on Capita. My name is Ros Hollingsworth. I'm the Global Medical Lead for Prevnar 13 at Pfizer. However, really, I'm here on behalf of my numerous colleagues and friends here in the US, in the UK, and particularly in the Netherlands, who have worked tirelessly over a large number of years now to get Capita implemented and completed successfully. So it's really on their behalf that I will be presenting these exciting data to you today from what is really an extraordinary study. Okay. This one? This one? Okay, I knew there'd be some technical difficulties. Pneumococcal pneumonia remains a significant public health problem for adults aged 65 years and older, as well as individuals younger than 65 years with underlying medical conditions that significantly increase their risk of pneumococcal disease. Given this unmet medical need, Capita, which is one of the largest vaccine efficacy studies ever conducted in the adult population, really had a key focus to demonstrate and confirm efficacy of Prevnar 13 for the prevention of vaccine-type community-acquired pneumonia, irrespective of whether that pneumonia was considered to be invasive or non-invasive. Indeed, this study met its primary and both secondary objectives, and with a safety profile that was consistent with that observed within our previous studies of Prevnar 13 in the adult population. So over the next 30 minutes, I'd like to give you an overview of Capita, the regulatory foundation underpinning the rationale and the need for the Capita study, give you an overview of the study design and the results, and then conclude with a short overview of the public health impact of the Prevnar 13 serotypes in community-acquired pneumonia among adults in the United States. So despite current vaccination strategies in infants and adults in the United States, hospitalizations due to all-cause pneumonia by 2009 in adults aged 65 years and older still remained in excess of 1,200 cases per 100,000 of the population annually. So it was this clear clinical need, plus the uncertainty surrounding the effectiveness of pneumococcal polysaccharide vaccines for the prevention particularly of non-bacteremic community-acquired pneumonia, that supported the approval of Prevnar 13 for adults aged 50 years and older in the United States under the FDA's accelerated approval program. The key focus of Capita was to confirm the efficacy under this regulations of Prevnar 13 to prevent a first episode of confirmed vaccine-type community-acquired pneumonia in adults aged 65 years and older. Capita was a randomized, double-blind, placebo-controlled study conducted in the Netherlands. 84,496 adults aged 65 years and older were randomized between September 2008 and January 2009 to receive a single dose of either Prevnar 13 or placebo. And this study population was then followed until a pre-specified number of vaccine-type community-acquired pneumonia cases had accrued. And this occurred in August of 2013. Adults had to be 65 years or older at the time of study entry, male or female. They had to be ambulatory and living in the community and registered with a GP who was happy to refer subjects into the study. They could not have received any prior pneumococcal vaccine. They had to be considered immunocompetent at the time that they were vaccinated. And obviously the typical contraindications to immunization applied. However, subjects could have underlying medical conditions which are typically associated with an increased risk of pneumococcal infection, such as chronic heart disease, lung disease, diabetes, and so on. This slide gives you an overview of the study objectives. There was one primary and two secondary objectives. The primary objective was to demonstrate the efficacy of Prevnar 13 in the prevention of a first episode of vaccine-type CAP, whether those cases were invasive or non-invasive. With respect to the secondary objectives, the first was to confirm efficacy for the prevention of a first episode of vaccine-type, non-bacteremic, non-invasive pneumococcal CAP. And the second was to confirm efficacy for the prevention of vaccine-type invasive pneumococcal disease, and those cases could have or not have pneumonia. So detection of vaccine serotypes within the Capita study was improved through Pfizer's development of a serotype-specific urinary antigen detection assay. Before development of this assay, there was no effective or efficient way of detecting serotypes, or more specifically vaccine serotypes, within cases of non-bacteremic, non-invasive pneumonia. And so to really facilitate the successful conclusion of this study, we needed a way to improve the identification of cases. So simply, microspheres are coated with highly specific monoclonal antibodies that are able to bind to the vaccine serotype pneumococcal polysaccharides that are excreted in the urine of adults with X-ray confirmed pneumonia. This assay has been fully validated, and the results of that validation have been published in the citation shown here. But this assay allows us to accurately identify the presence of any one of the Prevnar 13 serotypes with 97% sensitivity and 100% specificity among this patient population. So the map on your right, my left here shows you the 59 sentinel sites located across the Netherlands that were responsible for capturing cases and suspected cases of community-acquired pneumonia and invasive pneumococcal disease across the Netherlands among the patient population. So you can see we had a good geographical spread of these locations to try and ensure that we captured as many cases as possible. When study subjects are presented at one of these sentinel sites, their diagnostic workup included a chest X-ray, blood culture, and urine sample for Binax now testing according to typical standard of care. And then we also had a protocol-defined specification requirement for a urine sample to be sent to our Pearl River facility for testing using the serotype-specific UAD assay. The definition of community-acquired pneumonia was based on protocol-defined clinical criteria as well as X-ray findings that were consistent with pneumonia. And this was adjudicated in every case by an independent adjudication committee who had to confirm that each and every X-ray, if it was truly a vaccine-type CAP case, was consistent with the appearance of community-acquired pneumonia. So moving on to look at how we defined the primary and the secondary endpoints. So to be counted as a case of confirmed vaccine-type pneumococcal CAP, the individual had to be exhibiting 2 or more pre-specified clinical findings that are consistent with community-acquired pneumonia. Their chest X-ray appearance also had to be consistent with CAP, and we required a culture of a vaccine-type CAP, pneumococcus, from any sterile site and or a positive result from our SSUAD for one of the vaccine types. For the secondary endpoint of confirmed non-bacteremic, non-invasive vaccine type CAP, we wanted to be truly certain that these were absolutely non-invasive cases of vaccine type pneumococcal CAP. So we had, and again, X-ray consistency, clinical signs and symptoms that were consistent with CAP. But then we required identification of a vaccine type through our serotype-specific UAD assay. But for each and every case for this endpoint, all of these individuals had to have had a blood taken for culture. The results of that culture had to be negative, and if there were any other culture results available for any other sterile site, those also had to be negative. In terms of vaccine type IPD, this simply required isolation of a vaccine type pneumococcus from any normally sterile site, and so this included both pneumonia and non-pneumonia cases. This slide gives you an overview of the baseline characteristics of this subject population at the time that they presented for vaccination. So the mean age of this study population was 72.8 years and well balanced between the two groups. A little over 55% of the study population was male and again balanced. And although I've not shown you the other typical demographic characteristics on this slide, they were again very well balanced between the two groups. At the time that the individuals presented for vaccination, they were asked about their medical history. And they were asked specifically about the underlying medical conditions that you can see here. So in terms of patient-reported conditions, any patient-reported conditions of the ones shown here, around 40% of each group reported an underlying medical condition that might be expected to increase their risk of pneumococcal disease. Overall, 12% of each study vaccine group were current smokers. If we look at how this compares with the US population, these are data from the National Health and Interview Survey. And if you look at the green piece of the pie, 37% of adults aged 65 years and older reported, were considered immunocompetent, but reporting at least one chronic medical condition that would be considered to increase their risk of pneumococcal disease. So moving on to look at efficacy. As I mentioned at the beginning of my presentation, the study did meet its objectives. Both the primary and both secondary endpoints were met. Highly statistically significant results and a confidence interval that was well above 0 as pre-specified within the protocol. So looking first at the primary endpoint, there were 49 confirmed first episodes of vaccine type CAP among recipients of Prevnar 13, compared to 90 in the placebo group, for a point estimate of vaccine efficacy of 45.56%. For the secondary endpoint of non-bacteremic, non-invasive vaccine type pneumococcal CAP, 33 cases among the Prevnar 13 recipients, compared with 60 cases in the placebo group, for 45% vaccine efficacy. And as we would expect from our experience in pediatrics when we look at invasive pneumococcal disease, higher vaccine efficacy compared to non-invasive disease, with a point estimate of vaccine efficacy of 75%. We conducted a post hoc analysis to stratify by age. I have to emphasize that this was post hoc and the study was not powered to report age-specific efficacy rates, but I have provided that information for you. And you can see here that for those aged less than 75 years and those aged greater than 75 to less than 85 years, that the efficacy numbers are largely consistent with that observed in the overall study population for each endpoint. By the time we reach the 85s and olders, you can see that we had relatively small numbers of subjects, only around 1,500 subjects in each group of this age group, and this accounted only for 3.5% of the overall study population. So we really had insufficient numbers of cases in this oldest age group to be able to draw any conclusions about vaccine efficacy. We also conducted a post hoc analysis to look at serotype-specific efficacy, and again, the study was not powered to look on an individual basis. However, it's obviously of key interest. You will see here that despite the use of Prevnar in the Netherlands from 2006, and the replacement of that vaccine with a 10-valent pneumococcal conjugate vaccine in 2011 under a 3+1 schedule and with a 95% vaccine uptake. For the primary endpoint, we observed episodes of all 13 vaccine serotypes. The major contributions efficacy came from serotypes 1, 3, 7F, and 19A. And 7F was the only serotype under this post hoc analysis to demonstrate statistically significant efficacy at of approximately 77%. I've only shown here the primary endpoint data, but we saw a consistent picture for both secondary endpoints too. Another potential benefit based on conjugate vaccines' mechanism of action is the durability of protection that one might expect. And again, we also looked at this in an ad hoc manner. And the results are shown here. We had a mean duration of follow-up for our study subjects of 3.97 years. And this gives you cumulative case counts from days since vaccination for the Prevnar 13 group shown in blue and the placebo group shown in red. So you can see here that there's very early separation of the two lines, and that this separation is sustained through the duration of follow-up of this study, with no suggestion at the end of the follow-up period that efficacy may be beginning to wane. Another reassuring piece of information in regard to duration of protection are the results of the pre-specified interim analysis that we did not have access to until the study was complete and the data were unblinded. In September 2011, an interim analysis was conducted, and at that time, vaccine efficacy, although it did not reach statistical significance, was reported at 49%. So again, supporting this idea of a durability of protection across the duration of the study. We see a similar picture for both secondary endpoints. Again, non-bacteremic, non-invasive vaccine type cap in the top corner of this slide, and the vaccine type IPD in the bottom corner. Again, very good separation of the line and sustained separation. So that covers off on the key efficacy findings of the study. Now moving on to give some information about safety. We had within the study design an immunogenicity subset, and I don't yet have the immunogenicity data to share with you. However, this study population, or this study subset, also reported local and systemic reactions through 7 days following vaccination via an e-diary. There was around 2,000 of these subjects in total, and so these are the results that I'll present to you now. So looking at local reactions, as we would expect, comparing Prevnar 13 to placebo, a statistically significant difference among individuals reporting any local reaction. However, reassuringly, that you'll see that there was no difference between the groups in the frequency or prevalence of reports of severe local reactions. This pattern of of local reactions is entirely consistent with that which we observed within our regulatory trials that supported licensure of this product for adults. Similarly, for systemic events, we see differences between the Prevnar 13 group and the placebo group in terms of those events reported in the 7 days following vaccination. But again, a very consistent profile with that which we saw in our earlier studies of Prevnar 13 in the adult population. Serious adverse events were reported for all study subjects through 28 days following vaccination. And you can see here that the two groups were well balanced in terms of the number of reports of serious adverse events. Information on mortality was collected for all study subjects right through the case accrual period. And again, you can see 3,006 deaths reported among individuals receiving Prevnar 13 versus 3,005 in the placebo arm. None of these deaths or the serious adverse events were considered by the principal investigator to be related to the vaccine. If we look more specifically at deaths due to all-cause CAP or IPD, we can see that among recipients of Prevnar 13, there were 62 deaths due to CAP of any cause versus 70 in the placebo group. For IPD, 4 cases among Prevnar 13 recipients, 5 among placebo. So that really covers off on Capita, one of the largest vaccine efficacy studies ever conducted, and it was a huge, we were very pleased, I would say, to see the results of this study and to see the outcome both on bacteremic and not bacteremic community-acquired pneumonia. Very pleased and relieved, I would say. So, the other question that's always asked is, well, okay, a vaccine efficacy, how is that going to translate into a potential public health impact through use of this vaccine? Now, one of the key components of the Capita study was that development of the serotype-specific UAD. And although it was developed for use in that study to help us identify vaccine-type CAP cases, it's now enjoying huge utility globally in terms of really giving us, for the first time, good epidemiological insights into the spectrum of the vaccine serotypes causing community-acquired pneumonia among adults. So this just gives you an overview of a number of studies that have now been conducted in North America and relating back to the Capita study, where we've tried to ask the question, what does the serotype distribution look like? How much of community-acquired pneumonia is due to the 13 serotypes included in this vaccine? Primarily in settings where pediatric conjugate vaccines are used. So on the two columns to this side of the slide, you can see study 4007 and 1147 that were both Pfizer-sponsored studies. We made the UAD available to the CDC to enable testing of their urine samples collected from the EPIC study, so that's in the middle column. Dr. Shelley McNeil and colleagues from Canada conducted a study using their PCAN or SOS surveillance system, and she was very good enough to allow me to present the data to you here today from that early readout of that study, and then Capita in the far column. So this focusing in first on studies 4007 and 1147. These were conducted in the United States looking at individuals, adults presenting to hospital with X-ray confirmed pneumonia. Study 4007 was conducted between February 2010 and October 2011, so encompassing the time period when US infants made the switch from Prevnar to Prevnar 13. Because of the exciting data that we saw from that study, we decided to resurrect that in a follow-on study, which is study 1147. And that study started in October of 2013. And we undertook an interim analysis, which included all cases of pneumonia that had accrued by January of 2014. So based on our UAD assay, you can see that study 4007 reported a Prevnar 13 serotype prevalence rate of 11%, whereas 1147, conducted 3 to 4 years later, reported a Prevnar 13 serotype prevalence rate of 13.6%. So these are studies that have been conducted well after the introduction of Prevnar into the infant immunization schedule here in the US, and even straddling that switch from Prevnar to Prevnar 13. Now, what was also interesting in both of these cases is that the Prevnar, the original Prevnar 7 serotypes, accounted for 25% of the numbers that you see here. The additional 6 serotypes accounted for the remaining 75%. So from the EPIC study, we saw a serotype prevalence rate of about 9% in that study, and in Canada, reporting 16% prevalence rate. Within Capita, for first episodes of community-acquired pneumonia, it was 14.2%. So from this, we're taking a conservative view that somewhere around 10% of all-cause community-acquired pneumonia in the United States is likely due to the Prevnar 13 serotypes. And we can take this number and apply it to the rate of hospitalization for all-cause CAP to try and understand what the burden of community-acquired pneumonia due to the vaccine serotypes looks like. So referring back to the Griffin data that was published in the New England Journal of Medicine in 2013 and that I showed you earlier this morning, by 2009, you'll see here the hospitalization rates of all-cause community-acquired pneumonia in adults aged 65 years and older. So ranging somewhere between 1,200 hospitalizations per 100,000 of the population annually, up to in excess of 4,300 cases. If we apply a 10% prevalence rate to these numbers, this gives us somewhere between 120 and 430 cases per 100,000, or I should say hospitalizations per 100,000 due to the Prevnar 13 serotypes within the United States in adults aged 65 years and older. And clearly, by then applying US population statistics, we can then define exactly how many cases that translates to, and that's what I've done here. So I've just taken the Prevnar 13 incidence rates and used that to very crudely calculate the numbers of hospitalizations. So we can see here that in 2009, we would estimate that there were around 29,000 hospitalizations due to the Prevnar 13 serotypes in community-acquired pneumonia among those aged 65 to 74 years, 31,000 in those aged 75 to 84, and 25,500 in the over 85s. If we add those together, that represents around 86,500 hospitalizations due to Prevnar 13 type CAP in this age group. And applying, again, very crudely, the vaccine efficacy numbers from Capita, potentially around 40,000 hospitalizations each year in the United States among those aged 65 years and older. So in conclusion, pneumococcal pneumonia and vaccine-type pneumococcal pneumonia continue to place a significant burden on adults in the United States aged 65 years and older, as well as younger adults with underlying medical conditions that increase their risk. Capita was really a significant study, not just because of its size, but because of the questions that we were trying to address in terms of prevention of non-bacteremic pneumonia and the technology that was developed to underpin and ensure the success of this study. Prevnar 13 demonstrated clinically relevant efficacy within that study for the prevention of vaccine type CAP, with a durability of protection of at least 4 years and with a safety profile that was consistent with that observed in previous studies of Prevnar 13 in adults. So with that, I'd like to thank you for your attention this morning. I'm finished speaking, but I'm happy to take any questions that you might have.
Okay, Dr. Vasquez.
Thank you for a great presentation. I have a question regarding the urine test for pneumococcus. I don't know if you have a slide or if you can tell us. When you looked at subjects who were bacteremic or had a positive sterile site culture, how did that correlate with the urine positive test, positive or negative?
Yeah, so within the validation study, we saw 97% sensitivity, 100% specificity. So there was good agreement between the blood culture results and the UAD results. We missed with the assay 1 case of serotype 3 within that validation study, but it's always better to miss cases and get false negatives than to get false positives. Within Capita itself, we looked again. We had 29 bacteremic cases where we could make that comparison. And again, we had good correlation between the blood culture results and the serotype that we were seeing in the urine. Again, we missed 1 case of serotype 3 with the UAD and 1 case of 6A, 6C.
So the sensitivity and specificity within the Capita study were similar to your pre-study
Yes, so we haven't
assessments.
recalculated it. The idea, the validation study was there to, provide that sensitivity and specificity, and we didn't want to redo that within the Capita study itself to validate it, if you will. But looking crudely at the numbers, yes, we believe it performed as well in Capita as it had done previously.
Dr. Harrison.
Yeah, so was there any evidence for vaccine serotype replacement? And also, I'll think of my second question in a second.
Okay, thank you. So we only have the vaccine serotype information in terms of non-vaccine serotypes from our culture results. And there were small numbers of the other serotypes that we identified through that route. So I think it's not really possible from this study to determine.
And my second question was vaccine efficacy by underlying medical conditions.
Yeah, it's a question that we're frequently asked, but given the small number of overall cases, we haven't been able to look by individual comorbid conditions. The other difficulty is that most of the subjects within this study population, being over 65, had more than one underlying medical condition. So when we tried to separate out to look at individual conditions, we weren't able to do that.
Dr. Shukat.
I'm not sure if you were able to do this with the design, but did you look at vaccine efficacy against CAP with a negative urine?
With a negative.
The rest of the community-acquired pneumonias?
Yeah, so we looked at various, we're still undergoing a huge amount of analysis. We had a raft of exploratory endpoints. We did look at all-cause pneumonia, we looked at all pneumococcal, and I think I have a backup slide, yeah. So for a first episode of any pneumococcal CAP, irrespective of whether it was vaccine type or vaccine serotype or non-vaccine serotype, vaccine efficacy of 30% and reached statistical significance. For non-bacteremic, non-invasive pneumococcal CAP of any serotype, 24%, but did not reach statistical significance, and first episodes of IPD, as you can see here. We've also looked at all-cause CAP, in this case, first episodes of all-cause CAP, with 5% point estimate of efficacy, but did not reach statistical significance.
Dr. Kemp?
Yes, lovely presentation. Can you comment on the SSUAD assay and carriage of pneumococcus?
Yes, so the way that the cutoffs were defined for the UAD assay is a positive or negative assay. So the way that the cutoffs were defined for the UAD assay, they were each determined for each individual serotype specifically. We took a group of 400 adult control urines. So these were collected from individuals in the Netherlands and in the United States who were either considered completely healthy, with no evidence of respiratory infection, or they were undergoing elective surgery, again, no evidence of respiratory infection, and also individuals with COPD. So we assumed within that control urine population that we would have about a 5 to 10% carriage rate within the healthy adults or those undergoing elective surgery, with potentially a higher carriage rate among those with COPD. So the way that we then took those urines, ran them through the UAD assay, looked at the signals that were generated, and then set our cutoffs to be able to distinguish between the signals we're seeing in those healthy individuals versus what we're seeing in individuals with X-ray confirmed pneumonia.
And Dr. Reingold.
A lovely study, thank you. A quibble and a question. The question is, I know you're not powered to look at this, but can you tell us something about the efficacy by age in the younger versus older elderly people? And the quibble is in your second bullet point here, the 10%, it's certainly an underestimate of the burden of disease because you don't include all of the outpatient pneumonias, but it's not an underestimate of what proportion of cases are attributable to vaccine types.
Thank you. Yes, we did look at age. Let me return. Okay, so this gives you the primary and secondary objectives by age. So among those aged 75 years and under and between 75 and 85 years of age, the overall efficacy was consistent with that observed within the population overall. But you'll see that for the oldest age group, we really just had very small numbers of subjects of that age group in totality, but also then relatively small numbers of cases, and we can't really draw any conclusions. Okay.
Dr. Pickering?
Yes, yesterday we heard a talk on vaccine safety in children who received combinations of vaccines versus vaccines singly. In the Capita study, was there a subset of people who received both PCV13 and influenza? And if so, were there differences in adverse events that you looked at in this group compared to individuals who got pneumococcal alone or potentially even flu alone?
Yes, so we did have, at the beginning of the study, we did have co-administration of Prevnar 13 with TIV. Around 30% of the study population received both vaccines together. However, those individuals could not be included in our immunogenicity subset, and that was the group in which we measured local reactions and systemic events. So unfortunately, we don't have that solicited information in terms of the adverse event reporting, and I'm not aware that we've looked in the overall population in terms of SAEs as to whether there were any differences between those two groups.
And Dr. Schmader.
Thank you. Ken Schmader, American Geriatric Society. Thanks for a terrific presentation. Why were nursing home residents excluded?
Because they weren't considered to be true community-acquired pneumonia cases.
Okay. Are you planning to do some follow-up in that sizable population that develops pneumonia at a rapid rate?
Not at the moment,
Okay.
But always welcome to hear good ideas.
You have Dr. Weber?
Yes. In the bacteremic patients, what percentage of those patients were the vaccine serotypes coverage? What was the coverage for those?
So within the, I think, I have this in a backup slide if you'll just bear with me. I think somewhere I scooted past it. I apologize, it's at times like this you wish you hadn't put builds on your slides. There we go. So this gives you an overview of serotype-specific efficacy for invasive pneumococcal disease. So the only serotype we didn't see in IPD was 23F. All other 12 serotypes were present within this study population, and we saw a very similar picture to the one we observed for the primary endpoint in terms of 1, 3, 7F, and 19A making the major contributions.
My question is, were 50%, 40%, 90% of the bacterial diseases caused by a vaccine serotype?
I don't think we have that information.
Dr. Schuckett.
Have you been able to look at the the efficacy against community-acquired pneumonia in those who got both Prevnar 13 and flu versus those who just got Prevnar 13?
No, unfortunately not. Again, given the small number of overall cases and bearing in mind the only 30% of the study population received both vaccines together, it's just not possible from a powering perspective to do that.
Really? Because 30% of 85,000 people is bigger than most studies that have been done against flu. So
yeah, so it was just, we were only looking for a total number of cases overall of 130. We ended up with 139. So that was the major determinant.
Dr. Pellegrini, and then I think I'm going to, unfortunately, cap, so to speak, the discussion to move on to the next, but please.
Thank you for the honorary doctor, Dr. Tempe. Could we go back for a moment to the slide where you showed the breakout of the 3 age groups again, following up on Dr. Reingold's comment? It does seem surprising that such a small number of cases occurred in the oldest age group. And
yeah, so
do you have any, is it because of the size that the number that were recruited in the first place? Or,
yeah, so we only had...
Or are they all in nursing homes?
Oh, I've gone past it. There we go. Okay, yeah, we only had around 1,500 subjects in each vaccine group that were over 85 years of age. So detecting small numbers of individuals, small numbers of cases within that.
Was there something you think in the recruitment process or otherwise that resulted in the small numbers over 85?
I think it probably just reflects the population demographics that, there's not such a big pool to collect over 85s from, unfortunately.
Thank you. If we can have Dr. Stecker come on up.
Good morning. Thank you for this opportunity. I'm Charles Stecker from Tulane University. I have no conflicts of interest to declare. So I'm going to be talking about the economic analysis. We're going to use a cost-effectiveness model to look at either adding PCV for older adults or removing the risk-based recommendation of the polysaccharide vaccine. We're going to look at program cost savings, changes in disease, medical costs, non-medical costs. We're going to look from the societal perspective. Our population, we're going to have 2 models here, one looking at a cohort of 50-year-olds and one looking at a cohort of 65-year-olds as appropriate for whichever strategy we're analyzing. And we're going to exclude the immunocompromised from our model since we've already got a recommendation for that group. Here are the primary strategies we're going to look at today. Strategy 1 is PCV 13 at age 50. So this excludes the risk-based recommendation for those 50 to 64. PCV 13 at 65. So for strategy 1, we're going to look at a cohort of 50-year-olds. For strategy 2, we'll look at a cohort of 65-year-olds and so forth. For strategy 3, we'll look at both vaccines at 50. For strategy 4, both vaccines at 65. And then the next 3 will include the risk-based strategy. So strategy 5 preserves the risk-based recommendation and adds PCV 13 at age 50. Strategy 6 preserves the risk-based recommendation and adds the polysaccharide. So both of these, both 4 and 5, preserve the polysaccharide recommendation at 65. And strategy 6 adds PCV 13 at 65. And then strategy 7 preserves the risk-based recommendation and replaces the polysaccharide dose at 65 with the conjugate dose at 65. And we're going to take each of these 7 strategies and we're going to compare them to the current strategy, which is the polysaccharide for high risk between 50 and 64 and the polysaccharide for everyone at 65. So we're going to track today's 50 or 65-year-olds through life expectancy or until age 100. We'll look at disease rates now. So this is 2013, actually. We're going to project herd impacts from the child immunization program ahead by 6 years. We're going to look at all outcomes and costs discounted by 3%, and all costs are going to be expressed in 2013 dollars. So we're looking at a cohort model. We're looking at cost per quality adjusted life year gained, and also we'll look at cost per life year gained. We'll use the two cohorts, this cohort of 50-year-olds for those that change the strategy for 50-year-olds, and then we'll use a cohort of 65-year-olds for those that do not deviate from the current recommendation until age 65. We'll compare each recommendation to the status quo, and we'll calculate the incremental cost effectiveness ratio. So we'll divide change in costs by change in quality adjusted life years. Here are the health outcomes that we'll look at. We'll look at cases of invasive pneumococcal disease, cases of non-bacteremic pneumonia, either hospitalized or treated in an outpatient setting. We'll look at deaths due to IPD, deaths due to non-bacteremic pneumonia, quality adjusted life years, and life years. So here we get to the inputs into our model. So here is the disease burden due to invasive pneumococcal disease. We've broken our model into two risk groups, healthy, 50 to 64, and then high risk, 50 to 64, and then healthy and high risk, 65 plus. So our IPD rate is lower in the 50 to 64, and then higher in the 65, as you can see there. We have the distribution the percent of cases, IPD cases resulting in fatality, right here, ranging from 6 to 15%. We have the distribution of invasive disease due to PCV13 serotypes, along the bottom here, ranging from around 25%, and then the distribution of disease due to PCV23 serotype, the serotypes in PCV23 that are not in PCV13 are in this row down here, and then the non-vaccine serotypes are in this row here. And this is actually from 2013 ABC's data. We also have disease rates for non-bacteremic disease. We have the inpatient NBP rate per 100,000 separately for the 50 to 64 and the 65 plus. We have the percent of non-bacteremic cases resulting in fatality, the outpatient non-bacteremic rate per 100,000, and then the percent of non-bacteremic cases that come from PCV13 serotypes we use as 10. Our vaccine effectiveness numbers are here. PCV13 against vaccine type IPD, we use as 75% effectiveness. PCV13 versus vaccine type non-bacteremic pneumonia, we use 45% effectiveness. For the polysaccharide vaccine against vaccine type, we use 75, and then in our base case, polysaccharide against vaccine type non-bacteremic pneumonia, we use 0. So these are the herd effects from the childhood program, and these turn out to be very important in the model. We have here changes separately for the 50 to 64-year-olds and the 65-year-olds for the serotypes, either non-vaccine type, that's neither in the polysaccharide nor the conjugate, for PCV7, or those in PCV23 not in PCV7. And we have the changes from 2003 to 2009. So looking down the column at the end, we can see the percent change. So we can see that non-vaccine type, that's not in either of the vaccines, increased by 38.9% for the 50 to 64-year-olds. The PCV7 type in 50 to 64-year-olds decreased by 78.6%. And the types that were in PPSV 23 but not in PCV7 increased by 77.9%. So in our model, what we're going to do is we're going to take these changes and apply them to the new types in PCV13. So those are PCV6 types. So we'll take PCV6 types and decrease them by 78.6% to try to match the herd impacts that we've observed for PCV7 to those that we anticipate for PCV13. And then we'll do the same thing separately for the 65 plus age group. Here's what we use for coverage rates. So for the high-risk 50 to 64-year-olds, we use a coverage rate of 20%. This is from the National Health Interview Survey. For 65 plus, we use around 60%. For the healthy 50 to 64, this is important for the age-based 50-year-old recommendation. We take the ratio of people that have seen a doctor within the last year among the 65-year-olds and above among the 50-year-olds, and take that ratio and apply it to this, and then we take the average of the resulting number and this 20% to arrive at a 37.1% coverage rate for the 50 to 64-year-old healthy population. For vaccine cost numbers, we use separate costs for the 50 to 64 and for the 65 plus to represent different insurance statuses. These vaccine costs come from the CDC price list for 2013. All numbers are in 2013 dollars. So for the low price for PPSV 23 under a public contract is $23. And then we'll do some sensitivity analysis around these prices for PCV 13. Vaccine administration and travel and time cost we also include for each dose. For disease cost, we have the numbers in the base case right here. So the numbers are, this is invasive pneumococcal disease, non-bacteremic pneumonia in the inpatient setting, the outpatient setting, non-bacteremic pneumonia, separately for the 50 to 64 and for the 65 plus. Again, different types of insurance reflects different costs for these two groups. So the quality adjusted life year decrements, in our base case, we use quality adjusted life year decrements from Melgaro and Edmonds. So the decrements are here in the first column. So a case of IPD will cost you 0.008665 of a quality adjusted life year. So that works out to about 3.2 healthy days of life lost per incident of invasive disease. If we look at the implied duration of illness, so we apply this to another study that found that having having invasive pneumococcal disease decreased your quality of life by about 10%. So we take that 10% and divide it by the 3.2 here, and we come up with an implied duration of illness of about 21 days when we use these quality adjusted life years, assuming that IPD is worth about 0.9 of a healthy day. Similarly, for inpatient non-bacteremic pneumonia, we use this quality decrement here, which is about 2.2 days of healthy life lost per incident of disease, and that works out to a duration of illness of about 15 days. And then for outpatient non-bacteremic pneumonia, we use this number here, which is about 1.5 days of healthy life lost. Now, there's the quality decrements that we use turn out to be somewhat important, so we also use an alternative source that I'll go through on the next slide. So these are taken from different studies, and they're about 10 times larger. So we're looking at days of healthy life lost of about 27.2 days, and the implied duration of illness using the 90%. A day with IPD is worth about 90% of a healthy day. The implied duration of illness is about 181 days, and so we'll show results with both sets of these quality adjusted life years. For vaccine immunity, our waning profile for 50-year-olds looks like this. So this red line is the polysaccharide vaccine, which wanes to 0 by about 15 years. And then for the conjugate vaccine, it doesn't wane to 0. There's no waning until age 65. And then at age 65, we see a 10% decline in efficacy every 5 years. And so that's what that line looks like. If you start vaccination at 65 for those strategies that change the 65-year-old vaccination, it's the same as the previous slide, but without this no waning for PCV between ages 50 and 65. It looks like this, where again the red line is the polysaccharide and the blue line is the conjugate vaccine. So previewing the results, we have some dominated strategies. So these dominated strategies are generally the strategies that remove the risk-based polysaccharide recommendation. For the dominated strategies, we see increases in IPD. We see usually decreases in non-bacteremic pneumonia if we're adding the conjugate vaccine. And what we mean by dominated is we see a decrease in health measured by quality-adjusted life years or life years, and we see increases in cost. So it's worse for health and it's worse for cost. We see some health improving strategies, and these are the strategies that preserve the risk-based polysaccharide recommendation. We see increases in quality adjusted life years and life years, so we see more health in these strategies, and we also see increased cost. So here are the dominated strategies. These are the ones that remove the risk-based recommendation. So in general, these either decrease health or have very small improvements to health and very large costs. So instead, we're going to focus on the health improving strategies. So these are, again, adding PCV 13 to the current recommendation at either age 50 or 65, or replacing the age-based polysaccharide 65 recommendation with the conjugate. So here are the health outcomes for those three strategies. The three strategies are across the top: adding PCV at 50, adding PCV at 65, and then the replacement of PPSV with PCV at 65. The first row shows the change in invasive pneumococcal diseases relative to the current strategy. So adding PCV13 at 50 in our model will decrease IPD cases by 227, or adding it at 65 will decrease it by 226, or when we replace it, we see an increase of IPD cases by 1,298. For non-bacteremic pneumonia, we see each strategy decreases the number of non-bacteremic pneumonia cases. So the decrease here is smaller, and this is due probably to the lower coverage rates that we assumed for age-based recommendations in the 50-year-old age group. And then we see around 1,000 fewer cases of 5,000 fewer cases of hospitalized non-bacteremic pneumonia in the other two cases, other two strategies. And similarly for outpatient non-bacteremic pneumonia. For deaths, we see declines in deaths due to IPD under the first two strategies, and then an increase in deaths due to IPD under the third strategy, and then we see declines in deaths due to non-bacteremic pneumonia in all three strategies. All three strategies result in an increase in quality-adjusted life years. So these are the quality-adjusted life years that we get back in each of the three strategies. So the third strategy was the replacement. The increase in IPD is more than outweighed by the decreases in non-bacteremic pneumonia when we add up the quality-adjusted life years. And similarly down there for life years, we see the increases in life years due to each recommendation. So now we compare the costs among the three recommendations to the current strategy. So the top row here is the change in total costs. So adding PCV13 at 50 will increase costs by $687 million in our model. And these total costs are broken separately into medical costs, where we see declines in medical costs for each of the three strategies. So that reflects the lower amounts of disease due to the increased vaccinations. And then we see the increases in vaccination costs. So that includes travel and time costs as well. And then we take these total costs here and divide it by the quality-adjusted life years gained. And so we see that adding PCV13 at 50 costs about $461,000 per quality-adjusted life year gained. If, however, we added PCV13 at 65 instead, we would see a much lower cost per quality-adjusted life year gained of $62,000 per quality, and then a similar cost-effectiveness ratio for the replacement of PPSV 23 at 65 with PCV 13 of $46,000 per quality-adjusted life year. So there are some uncertainties in the analysis, and we want to do some sensitivity analysis around these. We're not sure about the quality numbers that we used, so the results I've showed you before so far have used the base case qualities, so we also use a set of higher qualities. It's possible that the vaccine price could change with this large increase in PCV orders, so we run an analysis where we assume that PCV 13 falls as low as the public price for PPSV 23, so we're assuming it costs $23.31 in 2013 dollars. And then we also look at how herd effects in the childhood program might affect these strategies in the long run. So we're going to look 6 years further down the road when the herd effects that we've seen so far from the PCV7 program in kids have manifested to an equal amount in the additional serotypes in PCV13. And we're going to focus this sensitivity analysis on the second two strategies here. So that's the adding PCV 13 at 65 and the replacement of PPSV at 65 with PCV 13. So here are the results for the sensitivity analysis when we add PCV 13 to the existing recommendations. So the first column shows the base case cost effectiveness ratios. So that was $62,000 per quality for the base case. If we use the higher quality decrements, we see a modest change down to $54,000 per quality adjusted life year. If, however, we use the low price, assuming that the price of the conjugate is as low as the lowest price for the polysaccharide, we see a very small $12,000 per quality. And then when we add them two together, we see a small change. And then the last column shows what would happen after the herd effects from the PCV13 use in children has manifested in the 6 additional serotypes in PCV13 by the same extent as we've seen herd effects in PCV7, and we see an increase to $272,000 per quality adjusted life year gained. So we do the same thing for the replacement. So again, here's the base case, $46,000 per QALY. We use higher decrements. We see a smaller cost per QALY. When we change the price to be as the lowest price we've seen for the pneumococcal vaccines, we see that this strategy would actually be cost saving. That means that health would improve and we would result in less total costs, even after accounting for the cost of the vaccines themselves. And then obviously once we further use the higher quality decrements, then we again see that results are cost savings. However, when we look 6 years ahead to the 2019 cohort, we see that results are dominated. So this means that we see an increase in costs, and we also see an increase or a decrease in health, as measured either by quality adjusted life years or life years. So we have some context for these quality-adjusted life year decrements. So here are some selected other interventions. So we see childhood HIB is cost-saving, as is typical of childhood vaccination interventions. Smoking cessation guidelines are very cheap at $4,000 per QALY. Sigmoidoscopy every 10 years is a modest $28,000 per QALY. Herpes zoster vaccination at 60 is about $80,000 per QALY. Biennial mammography screening for older women is $87,000 per QALY. For younger women, it's a higher $200,000 per QALY. Lyme disease, with very high attack rates, is about $250,000 per QALY. We have the value of a statistical life year here at about $500,000, and then just another possible intervention down here, Pap smears for low-risk women, costs $1.8 million per QALY. So that should give me some context for where these numbers seat in other interventions. So limitations of the study: there's uncertainty surrounding QALYs. So we've used 2 sets of QALYs here. There's uncertainty surrounding vaccine waning. So we've run some different ways to model that, not pictured here. And then the full PCV7 herd effects are projected forward on PCV6 types. So in summary, the cost per QALY is $50,000 to $60,000 per QALY under base case assumptions. So PCV13 for adults is comparable to other interventions accepted as cost effective when we either add PCV13 to the current schedule at 865, or we replace the PPSV 23 at 65 with PCV13. The simplified strategies that we initially considered that only consider age-based recommendations, excluding the high-risk polysaccharide recommendation, are generally dominated. Health effects vary between PPSV and PCV23. So PCV13 is obviously effective against non-bacteremic pneumonia, and in our model we've assumed that there's no efficacy of PPSV23 against non-bacteremic pneumonia. And we get more IPD when we exchange the PPSV23 dose for the PCV13 dose. However, after herd effects from the childhood program are fully realized, or at least 6 years more herd effects, then PCV13 adults is much less cost effective. Estimates range from dominated to $270,000 per QALY. Thank you.
Thank you. If there are any clarifying questions, we can take them now. Otherwise, we'll hold off on general questions until after the next presentation. I have just one quick clarifying question for you in terms of looking at the co-administration of the 2 vaccines. Did you model any synergistic effects at all?
No.
Dr. Gorman.
I didn't hear any discussion about the vaccine uptake rate, or does that not factor into your model at all?
Yeah, so here are our coverage rates. So for the high-risk group, we assume a coverage rate of about 20%. So this is for those in the risk-based recommendation. For the healthy 50 to 64-year-olds, we had to predict something since we don't have a analogous pneumococcal vaccine in this age group. So we used a 37.1% uptake for that group. And then for the 65 plus, we used close to 60%.
And a brief follow-up question, have you done sensitivity analysis based on coverage?
It's not shown here. In our multivariate sensitivity analysis, the most important factors were herd immunity from the KID program, the things that I went through, the quality adjusted life year, yeah.
Thank you.
Dr. Ernestine.
I just want, on your slide, I guess 12, you showed differences in cost by age, and I just was unsure what the rationale for why vaccine cost was different by age.
We were trying to account for different insurance status by age. So these, at age 65 plus, you're on public insurance, and so your insurer will pay a lower price for vaccine than if you're on private insurance. And so the private insurance generally faces a higher price for vaccine.
Dr. Reingold.
Sorry, just one quick question. In your strategy that replaces the polysaccharide at 65 with the conjugate vaccine, I'm just wondering how sensitive that analysis is to assuming some efficacy against non-bacteremic pneumonia. You assume zero efficacy against non-bacteremic pneumonia, and that's obviously controversial, whether there's any efficacy. So I'm wondering how sensitive those numbers are to assuming, let's say, 50% or 40% or some level of efficacy against non-bacteremic pneumonia.
So we have conducted sensitivity analysis around that. I don't remember exactly how sensitive it is to those, but again, the three main drivers of the cost effectiveness ratios are the herd immunity, the QALYs, and the waning.
Okay, Dr. Kim, one more.
I'm just trying to put together the last presentation with the herd immunity data. And this may be a clarifying question for the previous speaker, but there was a 10% rate of PCV 13 related community-acquired pneumonia. And that was in a program that was 95, there was 95% coverage and was a fully mature program, I believe.
So there's the EPIC study, which was also in the U.S.
Okay.
So in our model,
do our assumptions go along with that?
Yeah, so in our model, as a base case, we use 10% community-acquired pneumonia attributed to PCV 13 types. Then to account, so that's not accounting for, that's the current state of the world and not accounting for projected changes in herd immunity. So to account for projected changes in herd immunity, we assume that the serotype distribution in NBP is the same as in IPD. And so we observe the IPD changes from ABC's data on this slide, and we apply these changes to what we think are the PCV6 types in the 10% of community-acquired pneumonia that is due to PCV 13 types. So we knock that 10% down by, well, I can't do that in my head, but we knock it down to account for PCV6 types.
Okay, thank you.